I'm going to go ahead and get started. I want to welcome everybody for coming to our healthcare town hall. We thank you all for making it this evening. This event is being was organized and hosted by Indivisible Monroe County, Illinois. And if you would like to know more, if you don't know much about us and like to know more, there is a table right back there. It's got all kinds of literature. I don't know, are there any buttons back there, Paul? No buttons. Oh, okay, sorry. But there's literature. If you'd like to get on the email list, they can sign up for that. So that's right back there. And let's see. I am Cindy McMullen, and I'm going to be your MC for the evening. And that's all I'm going to say about that. The purpose of this evening is to raise awareness about the issue of healthcare, what's happening with healthcare in our communities, but also to collect much needed donations for our local food pantries. As we know, SNAP benefits still aren't where they need to be, and we have federal employees who still aren't getting paid, so our donations are greatly needed. So I want to thank you all for donating to that for us. Okay, tonight our focus is going to be on the impact of recent cuts and cuts to and restrictions on Medicaid, Medicare, and the ACA, and the impact this will have on our community. Tonight we have experts in the healthcare industry here who will present their view of the situation. And we have some of your neighbors who have been directly impacted by the changes, and they will provide testimonials to explain the negative impacts on their healthcare. The goal is that by the end of the evening, we will all better understand these changes and the effects they are having on everyone, not just those utilizing government assistance. Before we begin with our lineup of speakers, I would like to just say we were going to have some representatives from Senator Duckworth's office. Unfortunately, Jen was not able to stay, but she did leave her business card. She is part of Senator Duckworth's community outreach office, and I think their office is in Belleville. She has some business cards here, and she left forms. I'll be glad to pass these out later. If you have an issue with a federal agency, the VA, Social Security, Medicare, whatever, and you would like to get assistance from Senator Duckworth's office, you can fill out the form, you can email it to her, you can take a picture, send it. You can go to the office in Belleville if you wish and talk to Jen. She's very happy to talk to anybody who wants to come see her. So I have that information. I just want to let you know. We're also pleased to say that Julie Fortier, she is the congressional candidate for Illinois District 12. She is here with us this evening, and we're going to give her an opportunity to introduce herself later on in the program. Is that okay, Julie? Yeah. Okay. You're cool with that. All right. Let's see, what else? We did invite Representative Mike Bost as well to come tonight, so, But somebody reminded me, he's back in D.C. probably, Yeah, right. So, but yeah, we never heard from him, so anyway. All right, and after the speakers, we do hope to have time for some Q&A, if you have comments or whatever. This is being recorded as well, right, Paul? You want to just mention that? And it will be put on the Indivisible Monroe County Facebook page. Okay, and we're live streaming as well although we're limited to an hour, so I think we're going to start the second half. But this is being live streamed through the Indivisible Monroe County Illinois Facebook page. So just so you're all aware, that's all that's going on. All right. So let's see. All right. So we will have time for the question and answers. Let's go ahead and get started with our speakers. And our first speaker for the evening is Carolyn Atchley. She is a local mom, wife, and engaged member of our community. Carolyn is also a cancer patient who has faced firsthand the challenges of navigating our nation's healthcare system. Today, she's here to share her personal story, not only as someone seeking care, but as someone advocating for a system that truly serves people and families in moments of greatest needs. So please join me in welcoming Carolyn Atchley.
I hate talking on a mic. Okay, is this the right place for me? Okay. Awesome. Thank you so much for having me tonight. Thank you to Paul. Thank you to Indivisible Monroe County for setting this all up. And thank you all so much for you just showing up and, hearing what we've all got to say tonight. So in July of 2020, kind of when we were deep into like the really scary part of the pandemic where things were happening, people were dying, it was before we had vaccinations, and we were kind of in that point where life had really paused. I found a lump in my breast. And so I immediately called my doctor, and I got really lucky. He got me in really quickly. So I went to see my general practitioner, and, even though he did a really good job of assuring me that this was probably nothing and just a cyst, just to make sure, he held me at that appointment until he could get me immediately across the street. This was in O'Fallon, so he sent me across the street to St. Elizabeth's Hospital. So on that same day, he sent me in for an ultrasound and directed the results to be immediately sent back to his office. So I was at the hospital waiting for my ultrasound. They do that, comes back. They said, we're going to hold you for one more thing. And they sent me in for the second level ultrasound, which is a diagnostic ultrasound where they can see more. So after that, they still held me on for one more time. And so on that same day, I ended up getting a diagnostic ultrasound. And so even though all throughout this day, I'm being held at the hospital, I'm being held up, everybody was really positive. And they were like, don't worry, this is probably nothing, but we're just going to keep going through the steps. So I go home on that day after I'd had 2 mammograms, an ultrasound, a checkup from my doctor, and my doctor calls me getting into the nighttime where I was like, oh, look at this guy. And he said, hey, we've got an appointment with you the next day at a surgeon's office. And so by the very next day, I was in a surgeon's office having a biopsy. Biopsy was positive. We found out that I was diagnosed with stage 3 cancer. So at that time, we knew for sure that I had 3 tumors. And then we knew for sure that also there were some lymph nodes involved. So that's kind of what you get when you're a stage 3 diagnosis. And after that, everything started to move really quickly, which in hindsight is good. But at the time when everything's happening, everything gets really like overwhelming and what I like to call like the dark and scary times. I started chemo within about 2 weeks. I started with a chemo regimen that is standard of care for breast cancer patients that were diagnosed like me. It turns out I have more of a rare, extremely aggressive form of breast cancer. And so I started on that first protocol of chemo. I had 3 rounds of that. And within that 3 rounds of chemo, I had grown 2 more tumors. And so they said, okay, this is not working. And so then they switched my chemo regimen. So this is fairly well known among people that have breast cancer, but if you haven't had a lot of experience with that, they moved me to adriamycin, which is referred to as the Red Devil. Adriamycin is a chemo that is so toxic that the nurses wear a hazmat suit when they give it to you. And while I was on adriamycin, the red devil that is, we can't say promised, but is likely to kill everything, I grew 2 more tumors. And so as I'm just like busy having chemo, growing tumors, my doctors finally said, like, this is not working. This is not working for you. And so on a Thursday, we decided that it would be in my best interest to have an emergency double mastectomy. And so my insurance said, an emergency double mastectomy? That's not a real thing. And so they refused to cover my mastectomy. So in order to get me in, my doctors were sure that retroactively they would cover it. And eventually they did. But before I could go in to have surgery, my husband and I had to sign a paper saying that we would cover it financially if my insurance didn't cover it. And that we'd be responsible for $150,000 for the surgery. We didn't really have a choice, so that's what we did. So I had surgery and started on another final round of chemo, or another chemo regimen called Kadcyla, which that one they call Godzilla. So, good times in the chemo world. But because my cancer was so severe, it had by that time spread to my bones. And so we kind of got to a really scary place. I was going to Siteman, which, in this area is the gold standard of care. And unfortunately, they kind of came to us after a few months and said, we're running out of options for you. I didn't know this at the time, but while I was in the restroom, they told my husband that it would probably be a good idea for us to start getting my affairs in order. So among all this, when we're starting to run out of options, we get to that desperation point. And so my doctors put me in a worldwide clinical match program. Keep in mind that this is during the pandemic, so it wasn't really like the best time to travel. But luckily, they found a match for me. Again, when you have cancer, I didn't really realize, but there's a lot of like really specific parameters that you have to fall into. And so I only matched with 2 different trials that were happening in the entire world. So I honestly got really lucky that one of them happened to be at the Mayo Clinic in Rochester, Minnesota. And so at that time, I started doing Kadcyla. So I did 17 rounds of chemo. So every 3 weeks, I did chemo for a little over a year. And in that time, we were traveling every 3 weeks to the Mayo Clinic for me to start this clinical trial. I won't lie, the clinical trial was hard. Chemo was hard, and I was one of those people who, we always like to joke, I got basically every side effect that you could get. I had multiple surgeries. I had lots of infections. I had my spleen removed because it kept getting infected. I've had a double mastectomy. I've had a full hysterectomy. I have stage 2 lymphedema. I have, because my cancer is estrogen positive, it's hormone positive across the board. Every hormone in my body feeds my cancer. So I'll, for the rest of my life, be on drugs that draw all of those hormones out of my body. And so since I don't have any estrogen, I also have menopause, and I'm losing track of the word right now. What's when your bones break? Osteoporosis. Thanks. See, this is my true life. Yeah, I have osteoporosis. And so I've broken 3 bones just from like literally walking into things. So it's been a really rocky ride. So as I was going back and forth to the Mayo Clinic, I got connected with an amazing, amazing doctor who I was so fortunate for, and who honestly I credit with saving my life. And so not only was she one of the doctors that was part of this team that was on my clinical trial, but she's also really research forward. And so about 2 years ago, she came to me really excited because she had attended a medical conference and there was a drug coming on the scene that was going to be perfect for people like me called Lynparza. So Lynparza is a drug that had been on the scene for quite a while, about 10 years. It's a drug that was approved for ovarian cancer. And it was now having a lot of success in clinical trials for breast cancer. And so my doctor was waiting. She was like, as soon as we get that FDA approval, we're just waiting. As soon as we can get that FDA approval, I'll prescribe it to you. And she did. On the first day that hit FDA approval, I got prescribed that drug. Pardon me. And luckily, I have been, though I won't ever be probably no evidence of disease or in remission, I've been stable for the last 2 years. And for somebody like me, honestly, that's about a best case scenario. So, times have been tough. Things have been expensive. And I've fought a lot of battles. I've fought against my own body. I've fought against my doctors. I've fought against my insurance companies. But the one thing that I never really anticipated having to fight would be the federal government. So at the beginning of this administration, when Doge was on the scene and really, kind of doing its thing out there, my clinical trial at the Mayo Clinic was defunded. Yeah, it was 6 years into an 8-year trial. And so that was a drug that I almost instantly lost access to. And then in May, I found out that Lynparza, the drug kind of those two things are what were the new things for me that we had really been kind of attributing to what was keeping me stable. I found out that that drug hadn't gotten full FDA approval yet. It was sitting in kind of a limbo status for the FDA. So it had gotten temporary approval status since it was already approved as an ovarian drug. But it hadn't officially made it past that FDA approval. So it was still sitting in that, they gave it a temporary approval status so that people like me, people that were really desperate for this drug, could start having access to it even before it had gone through the full FDA approval process for breast cancer. Well, in May, RFK Jr. and, his hands-on FDA, they decided to remove all of those temporary approval statuses for drugs that were in that limbo status. So I then lost access to that drug. My doctor did say technically she could still write the prescription for this drug for me, but because it's not approved by the FDA anymore, my insurance won't pay for it. And the drug is $23,000 a month. So, it's been like a really kind of interesting ride being inside the medical system. But because people are always so exceedingly kind, I've been lucky enough for people in my life to always offer up, like, what can I do? Can I start a GoFundMe? Do you need dinners? Do you need a ride? What do you need? And while, I'm luckier than most people that my family and me have everything that we need, I do have an ask for people now. And it's to think of me when you vote. My story is just one among millions, but together our stories can become a force for change. Nobody that's fighting for their life should also have to fight for access, for affordability, for dignity. So as you go about your days, especially as you're taking part in the decisions that affect all of our lives, I do ask that you carry my story with you, me and all the people that are like me. Remember the families and the faces that are behind every policy, and let compassion guide you. Because the way that we care for each other, both in sickness and in health, says everything about who we are as a nation. Thank you so much.
Carolyn, I think I speak for everybody in this room that we will be thinking about you whenever we vote, definitely. Thank you for sharing your story with us. Okay. Our next speaker this evening is Stephanie Sabo. Stephanie is a registered respiratory therapist with over 10 years of experience in healthcare and a master's in healthcare administration. With that, Stephanie brings both clinical expertise and compassionate leadership to the field. With more than 5 years serving in rural health settings, she has developed a deep understanding of the unique challenges faced by underserved communities. Specializing in the care of patients with pulmonary impairments such as COPD and asthma, Stephanie is committed to improving respiratory health outcomes through patient education, evidence-based practice, and community outreach. Beyond professional practice, Stephanie is also a mother of 2 children with asthma whose care is supported through Medicaid, an experience that fuels her advocacy for equitable access to quality health care for all families. So please welcome Stephanie.
Thank you, everyone. Thank you for coming. Again, my name is Stephanie. I'm a registered respiratory therapist from Southern Illinois. I have worked in healthcare for over 10 years, and for the past 5 of them, I have served patients in a small rural access hospital. I am also a single parent of 3 children, 2 of them who have asthma and rely on Medicaid for their life-saving medications. Every day I see firsthand how critical programs like Medicaid, Medicare, and the Affordable Care Act are for families in our community. With these supports, many of my patients and even my own children would not be able to afford the medications and the care that they do need. Cuts of these programs just don't mean higher costs. They mean real people going without treatment, ending up in emergency rooms, and facing the impossible choices between paying for food, rent, or their health. I've had patients skip refilling their prescriptions such as their inhalers already because they had to pay for groceries. Right now, inhalers, the cost is still high, even with the Affordable Care Act. So, and those health care subsidies. I've seen families come in with children who have are in respiratory distress because they can't afford preventive care. And I have watched patients to be remitted time and time again, not because their illness was untreatable, but because their coverage was unstable. These are not numbers on a spreadsheet, these are lives. When a rural hospital shuts down, the average drive to care increases by 20 to 40 miles, which for some patients is the difference between getting treatment and going without. I already have seen patients right now that transportation, especially in this rural area, is a key issue. So trying to get to those specialty appointments, see those specialists, even for pulmonology, and that's already low. Pulmonologists are not very frequent around here. You have to travel to St. Louis or Belleville, or, there's one in Sparta, but they fill up quick and fast. So wait times are high. Our hospitals depend on Medicaid and Medicare funding to keep their doors open, pay their nurses and doctors, and also maintain critical service like ER care or even respiratory therapy care. Under respiratory therapy, we are considered an ancillary department, meaning that our department is fueled by revenue and volume. So we are definitely, whenever hospitals like to start cutting staff, your ancillary departments such as respiratory therapy, who are your key figures on managing that respiratory distress, health, COPD, asthma. We are a key player in that. You come into the emergency room and you have to be on BiPAP, CPAP, or intubated with a vent. We are the ones managing that. Those services will get cut, and then the nurses and doctors start having more responsibility on taking care of that patient, and they're already overburdened trying to take care of other nursing and other oh my gosh, I lost my train of thought. Sorry, other issues for that patient. It's a team effort whenever in the hospital setting. Everyone has their own set of responsibilities and to take care of the patient, and whenever you start cutting staff, that puts more burden on those doctors and nurses. If those resources are cut, we risk losing jobs, reducing services, and forcing patients, many of them who don't have reliable transportation, to travel hours for care. For someone in a medical crisis, that's just not an inconvenience. It can be deadly. I urge everybody, especially everybody urging their leaders, to remember that behind every statistic is a family, a child, a neighbor. Protecting Medicare, Medicaid, and ACA subsidies isn't just about numbers. It's about life-saving and supporting our communities. Every day, I am reminded that good breathing is about more than just lungs. It's about quality of life, connection, and the ability to thrive. I appreciate everyone coming. I appreciate everyone listening to my story in regards to that. Even with personally my own personal with Medicaid, I couldn't be able to afford the inhalers my children have. If it wasn't for Medicaid. In regards to that, they would be more symptomatic than they are now. Asthma is a very difficult chronic disease that you live for the rest of your life to manage. So please, let's urge our leaders. Let's fight as a community. We are better, greater with numbers. So please, thank you.
Thank you, Stephanie. All right, continuing on. Our next speaker is Chastity Mays. Chastity is co-administrator for the Little Resource Center in Carbondale and is a certified birth doula. She has been working in family service and peer support spaces for over 15 years. She has served clients in Southern Illinois, the Missouri Boot Heel area, and Paducah, Kentucky. She stands with and advocates for families who are underrepresented in, and in many cases, simply not heard at all. Chastity is routinely involved in state and regional political efforts around Black maternal health and frequently presents her expertise and experience in public forums, conferences, and through legislative testimony. Chastity believes that representation and cultural awareness is vital to changing the exorbitant Black maternal mortality rate. Chastity?
Thank you so much for having me here tonight. I really appreciate it. As she stated, I am a birth doula, and I've been a birth doula for 6 years now. It is absolutely my passion to serve families, and I don't think people understand the crucial role that doulas play. What we do is we provide like a grassroots level of care to the families. So we are not medical providers, we're support. So I provide emotional support, education support, and physical support to my families. The way my services work is I meet the family where they are. I meet people when they're peeing on the stick. And then I also meet them. I have went into the hospital when I've never met the family before, but they need that support. So the hospital has called me, a family member, and I go in and provide that support. I usually try to have 3 visits with my families before they have their baby, and we prepare. And then I go in the doors of the hospital with my clients. I stay with them until they have their baby, and then I stay 6 weeks postpartum. So these are actually my doula clients. These are real families. I have a relationship with all of them to this day. So if you look at this couple on the bottom right, their son is 3. She just texted me last week, Chastity, he hit his head, what do I do? So just having that support from someone that you can reach out to is really crucial and key. Something that was a big eye-opener for me was the amount of times I have been the only person in the room with that mom having a baby. There's no family. There's no one. Even when I ask them, who is the emergency contact? If something were to happen, no one. So you have to realize how critical doula services are. It's really, really important to families. Something else I'll tell you is last week I had a consultation with a young couple. They're 26 years old. They recently lost their food stamps and they're struggling to eat. So as doulas, we provide them the resources that they need, which is a food pantry, right? They need food right now. They both work. These kids do not have food, struggling to eat, working. They just don't make enough money. You also have to realize that these families having Medicaid is so crucial. I have families who have had preeclampsia and stayed in the hospital in St. Louis, 2 hours from where they live, for months at a time. That means their families are stretched. Their families are having to go visit them. Somebody usually just stops their life. Usually it's like a grandma. They're able to do that and just goes and stays with these families. If somebody has preeclampsia, usually they're having their baby early. That means you have a baby who's in the NICU. If they did not have Medicaid, what would they do? We also have a huge Spanish-speaking population in Carbondale in Southern Illinois. And the immigrant population does get an emergency card for them to be able to have their baby. But a month after that, 30 days after that woman has her baby, she has no more services. That means she does not have food stamps. She does not have WIC, which my other clients have WIC to supplement formula, right? She cannot get those emergency diapers, wipes, those different types of services. Losing these critical, important pieces for a family is just devastating. I always say, if we're not taking care of our moms and our babies, what are we doing as a society? We have to put them first because these moms need this care. We have gestational diabetes is on the rise. And you guys, this is everybody. This is no matter who you are, white, black, yellow, gestational diabetes, preeclampsia, all of these things that are affecting families. And then now, if we're saying they have preeclampsia, they have gestational diabetes, now we're taking their food away. What are they supposed to eat? That means they're not eating healthy. They're not eating fresh foods. They're not getting the services that they need. So looking at these real families who I've served, who I still have a relationship with, realize that they may be losing their services. Can you move it forward for me? These are just some other of my families. The main question that I get after they have their baby is breastfeeding questions. If you take a look at the bottom right, we stayed up all night with her, just providing support. That's the picture we got in the morning. She was like, look, I got all this milk. So that was super amazing. So we are, as doulas, we are actually now in Illinois able to take Medicaid. So we provide, for these families, our services are free. We are able to do that now for a full year. So we provide the support while they're pregnant, labor and delivery, and then a full year postpartum. You can move it forward. Now, I do want to let you know that this was surprising for me even when I first became a doula. The United States ranks worst in maternal care in the entire world. That for me was like, what? We're supposed to be this great nation, but we're not serving our mothers. And if we're not serving our mothers, we're not going to be here anymore if moms aren't having babies, right? Like we all were born, all of our moms brought us into the world. So U.S. is worst. I will say that the best countries have midwifery care as a basis. And our country has obstetricians as a basis for our providers. That's the difference. Midwifery care provides that community level of care that a doula provides. So they're meeting the family where they are. Like if somebody has a home birth, their visits are an hour long. When you have a baby nowadays, you go to the provider. First of all, you never see the same person. You see a different provider every time you have a prenatal appointment. Then when you go to the hospital, whoever's on call is who delivers your baby. Sometimes my client has never met the person who delivers their baby. Then nurses switch shifts, right? So we're on a 12-hour shift, but that doula, I'm with you from the time I meet you until the time you have your baby. So that consistency is really important for clients. So yeah, this is key for people to really grasp and understand that we really need to do better with our maternal care for mothers. Something else I'll tell you is that all women are not listened to. All of them. Like I have clients and they call me and they say, Chastity, I just really think something's wrong. As a mom, you know when something's wrong. You know when your blood pressure's high. You know when something's wrong with your baby. They go to the doctor. Oh, you're pregnant. Well, I feel faint. Oh, you're just pregnant. It's not always pregnancy. Sometimes there's something wrong with the mom that needs to be taken care of. So if you would move to the next slide for me. So the reason why Black women are dying is in a hierarchy, we're just at the bottom of that totem pole. So if you're not listened to, I'm actually ignored like I don't exist. So when I go to the doctor, I might be drug seeking or, we just don't believe you. You don't know what you're talking about. So that's why Black women in Illinois are dying 6 times more than their white counterparts. And sometimes the reason is just racism. They just simply overlook our concerns and don't believe us because as doctors, sometimes they're just taught not to believe Black women. 72% of the deaths are preventable for Black women. I think the most impactful case for me was I had a teen client, and I always tell people, families just don't know what they don't know, right? As a doula, if you call me and you say at 20 weeks pregnant, you're swollen, that's not normal. That should not be happening. But her family, you know, her mom, her aunt, oh, it's okay. You know, you swell when you're pregnant. No, honey, not at 20 weeks pregnant. I even told her to go to the doctor, and they told her she was fine. I told her, send me a picture of your face. She sent me the picture, and I said, either your mom takes you right now or I'm coming to get you. We got to the emergency room. Her blood pressure was at stroke levels. They were able to get it down. She ended up in St. Louis for 3 months. That happened again 3 more times. She called me. I was able to get there. I was there for the birth of her baby. Her and baby are doing amazing. But if she didn't have a doula, I remember we were at the birth, her dad cried. And she told me, thank you for being here for us, because we don't want to think about what would have happened if you had not told us to be there. And part of Medicaid, part of insurance is having a doula for families. You go to the next slide for me. And I always tell people, I love this quote from Audre Lorde, I am not free while any woman is unfree, even when her shackles are very different from my own. This is everybody's issue, you all. Like I said, mothers are so important. We have to take care of our families. We have to make sure that they have food. We have to make sure that they have housing. We have to make sure that they keep their critical insurance. If these families, like think about this young couple, 26 years old, they're struggling to eat right now. If they lose their insurance, what's going to happen to her care? She's pregnant right now. She's not due until next year. If they were to have a deductible that went too high for them, she might just decide that she doesn't want to have this baby, or she doesn't have insurance. And then sometimes when someone doesn't have insurance, they don't realize you can still go to the hospital. They're still going to serve you, right? But there are some families who don't understand that. So they're not going to go to the hospital. They might be at home bleeding and scared to tell anyone. So we have to really, really take into account this is everyone's problem. If you don't know what a doula is, educate yourself. If you know someone who's pregnant, please tell them to get a doula. It doesn't matter who you are. Man, woman, young, old, Black, white, and everybody in between. Please, please think about mothers and think about who you vote for makes a difference to everyone in our country. Thank you.
The next speaker is Charles James. And Mr. James has been CEO of North American Healthcare Management Services. That's a medical billing company since 1992. His family has owned several clinics in the 1970s and 80s, which became some of the first certified rural health clinics in Missouri. Those family-owned clinics were purchased by a large hospital system in 1991. Charles has worked with rural primary care providers, small rural hospitals, and community health centers across the country ever since. He has served on the boards of several rural health associations, including a term as president of a national organization during the COVID-19 epidemic. Charles provides technical expertise to rural health associations across the country as a frequent speaker. And Charles has spent many years lobbying members of the U.S. House of Representatives and the Senate on issues affecting the delivery of rural primary care. So please welcome Mr. Charles James.
Thank you very much for inviting me to be here. I appreciate the opportunity to speak with you. I'm going to be super boring relative to the testimonial we just got from these three ladies. I'm much more technical, but just to tag on to what Chastity said, I too was shocked when I looked up maternal mortality rates in the U.S. not only are we at the bottom of industrialized nations, the last UN statistics had us between Belarus and Saudi Arabia for maternal mortality. And people are shocked when they hear that. I like to say we have the best healthcare and healthcare providers in the world. We have one of the worst systems for financing the care that we give. A lot of folks say, hey, we're a Christian country, but our healthcare system sure doesn't seem to reflect a lot of that. So thank you for all of your comments and testimonial on your experiences. It's just so scary what can happen to people when we don't have healthcare coverage. And all of us, rich, poor, white, black, brown, yellow, are just one health crisis away from bankruptcy. Medical bankruptcy is the number one driver of bankruptcy in the country. And how is that possible? So I do this a lot. I go around, give a lot of technical discussions about various micro issues related to our little niche of rural healthcare. So a little bit about me is my family, my dad's brothers were all doctors in central Missouri. And my uncle, they were a family practice guy, delivered babies, general surgeon, internal medicine. Family practice guy delivering babies delivered like 3,500 babies in a town of 2,600 people over the years. And I will tell you that how much things have changed. He delivered every single one of those babies and saw every one of those patients with 2 guns on him. Always had one on his belt and always had one in his boot. And you just think about that clinic operating now, and the world has changed several times since then. So I grew up with those guys, and we grew that organization into 9 locations, which at the time was very large, and 8 of those became rural health clinics, which I'm about to explain what they are. So I grew up in that. I said, I'm never going to go to work for the family. So, of course, exactly what happened is I got out of school and went directly to work for the family, and I've been doing this since 1991. So I thought in order to get our heads around what's happening in Congress with the One Big Beautiful Bill, that we really need a little bit of history about what the ACA is exactly and how it's structured, so we can talk about the potential damage that the One Big Beautiful Bill will do. Directly to Chastity's point, one thing I didn't even address in this are the maternal healthcare deserts that we're creating. What somebody like me doesn't realize is that an enormous percentage of our patients have massive transportation security problems. And getting 30 miles is a non-starter. Getting 5 or 6 miles to the doctor is a problem when you don't have a ride. And with these healthcare deserts come food deserts as well. And we just have this cascading series of problems that have large negative impacts on all of our community's healthcare. So I'm going to talk about these issues here. And I originally had this slide titled Original Sin, but I thought maybe that was too strong. So first of all, why do we have the healthcare coverage we do? Because after World War II, there was a big salary freeze, and labor shortages created an economic problem, and employers discovered we can't pay more. We have salaries frozen after World War II, so health benefits were not taxable, and we can attract workers by offering benefits through our employment. That's how this started. And then the federal government said those benefits are not going to be taxed, which is one thing Obamacare started to change. So this started way back after World War II. And then we were talking beforehand about the HMO Act of 1973, which codified not only for-profit medicine, which is what I refer to as our original sin. Profit motive in healthcare is our original sin. and what has really created a lot of negative consequences for our whole system. But it's also when HMOs and PPOs, point of service care plans, became prevalent. And then when my family were growing our organization through the 70s, we actually had one of the first HMOs that was very unsuccessful, and it drove it right into the ground because of overutilization. And again, it was a profit motive that created this problem. But that's when our PPOs, HMOs really got off the ground. So PPOs, preferred provider network. So think, oh, I have to go to this doctor that takes my insurance or else my claim is not going to get paid. So that's where all of that started. So I like to ask people, hey, who would you say runs our healthcare system? What would your answer be? CEOs. Who's that? CEOs. Good answer. Insurance companies. That's exactly right. I expected some of us to say, oh, the federal government runs it. Oh, no, Medicare runs it. No. As my attorney says, the golden rule is they with the gold make the rules. And so that's exactly where we are today, is the health insurance companies are running the show. Let's face it, sorry, politicians. A lot of our politicians' funding comes from healthcare companies, health insurance companies of all kinds of stripes, and there's a lot of power. There's a lot of economic power there. Healthcare is 25% of our economy. So there's a lot of money to fund political campaigns, and that's absolutely what happens. Our niche in healthcare has been with these types of providers, rural health clinics, critical access hospitals, community health centers, and all of these types of providers get paid based on their cost. So they have a very different reimbursement structure than if you go to Memorial Hospital and see a doctor in what we call a fee-for-service environment. Fee-for-service environment, you submit a claim for $200. Your insurance company is going to pay some strange allowable amount of that, which may be $83.37, and the insurance company writes off the difference. Who suffers in that scenario? Self-pay patients suffer because they pay the full amount of that healthcare claim. So our rural health clinics, our critical access hospitals, our community health centers are paid based on what it costs them to see a patient, plus a lot of variables. But most of our healthcare providers in rural areas are one of these three types of entities. And to show you how pervasive they've come, here are all the rural health clinics in the country. Now look at Illinois, and it's covered up, isn't it? It's covered up. So of course these rural health clinics correspond to population centers, so we have fewer of them out in the Desert West. And we're really focused here on in the Midwest and the SEC territories, et cetera, and down into Texas. And actually for a while, Missouri had the most rural health clinics in the country. And this is who we have served at our company primarily. Heavy Medicare, Medicaid populations. We rely on Medicare and Medicaid in our rural health clinics. That's who we're seeing. We typically have about 50% of our patients are Medicare, Medicaid. Another 35, 40% are commercial insurance, and another 10% are self-pay. And the reason we have such a low self-pay percentage is because of the Affordable Care Act. And we're going to talk about that momentarily. Here are critical access hospitals. I can't see the map very well. Where's Illinois? But you see in southern Illinois, and especially when you focus in on Illinois Congressional District 12, which we are, it's a huge district. We cross the entire state, and most of the hospitals that we think of in our district, Redbud, Pinckneyville, Nashville, Crawford Memorial in Robinson, Lawrenceville, wherever you can think of, except Belleville, are critical access hospitals. and they get paid basically 101% of their cost. Now, these critical access hospitals and rural health clinics have been suffering from what we call sequestration, which actually came about in the Obama years, which is a 2% haircut on every Medicare dollar they earn. So for every Medicare dollar they earn, they get paid 98 cents. You would think that is not much, but it actually has had an enormously negative impact. These critical access hospitals may run on a % or 2 of a profit margin. So if you take 2% away, you're taking away any money they make that then goes directly and takes away from ancillaries and other services. And what's the first thing to go? OB care. So we've had an enormous wipeout of OB care in these critical access hospitals because they just can't afford to staff and keep an OB unit. So already, this has already happened. We've had an enormous number of OB units across the state close, and this has been something we're battling. And then we hit this OBBB problem. So more about that in a second. Then our community health centers is a federally qualified health center. They get a couple different kinds of federal advantages. And when you hear community health centers discussed, they're typically some kind of FQHC. And you can see down in Southern Illinois, we actually have one big giant community health center that serves a lot of Southern Illinois, which is, you may know of Southern Illinois Healthcare. They're a big, well-established, well-entrenched community health center in Southern Illinois. And so these three types of entities, once you get out of any kind of urban, suburban area, are probably where you're being seen. Everybody in our industry is terribly fearful as soon as this one big beautiful bill hit. It's been, we're all fearful of impending catastrophe. Everybody's fearful of the uncertainty. One thing that happened to community health centers when the new administration took over is all of our grant funding got frozen. It was like a missile strike from our own capital. Because what happened is our community health centers is like if you go to your bank and they say, sorry, you can't get to your money right now. So they draw down on grants and they could not access their grant money. And then we thought, oh, wow, okay, we're in a new environment here. This is something different and not good. And then we get the One Big Beautiful Bill Act, and now, you know, the healthcare Armageddon that I've been fearing is a distinct possibility. Let's look at some Medicaid facts. Let's look at some facts, not political propaganda designed to degrade certain populations in our country. 19% is Medicaid funding. 25% of this is our healthcare spend, hospital healthcare spend in 2023. The statistics are in a couple of years old. For any of your research, I highly recommend Kaiser Family Foundation. They are a singular, preeminent source of nonpartisan, in-depth information. So when you hear Kaiser Family Foundation reporters on NPR, for example, you can put it in the bank what they're saying. They're nonpartisan, extremely well-developed organization, and they have great website resources. And almost everything I'm presenting to you today comes from Kaiser Family Foundation, including this map. So here's our spend, 25 and 19%. Boy, that's sure getting about 50% of our spend, isn't it, in healthcare? Yet we still have outcomes like Belarus and Saudi Arabia. How is that possible? How is that possible? Let's look here. Medicaid in Illinois. Medicaid adults. Remember from a previous administration when we had this term that, oh, they're a bunch of takers? Remember that? No, they're not. We're working. We're working. 70% of our Medicaid recipients are working, And the rest of them are not working, probably because of some kind of disability, or maybe they're in a nursing home. 69% of our nursing home residents are on Medicaid. How many of you have had family members that had to get rid of everything they have so they can afford to go into a nursing home? That's how. So when we're talking about Medicaid recipients, we're talking about people who are already working. We're talking about people on disability. We're talking about children. And we're talking about nursing home residents. And yes, expectant mothers get Medicaid benefits. So that's who we're dealing with. 13%, look at our district here. Medicaid covers from 13. I don't have an exact number for District 12, but we'll get there. Here's some what I thought were interesting demographics specific to our district. 26% of our residents, over a quarter, are on Medicaid for the reasons we just looked at. 7.2% are uninsured. You know why only 7.2% are uninsured? Because the ACA worked. That's what the ACA was supposed to do. It got people insurance. And you know how frightening the prospect of not having insurance is with a catastrophic diagnosis. 20% live in a designated primary care shortage. It's actually a very specific status for our counties. All of those counties that you see that had critical access hospitals, rural health clinics, or community health centers are all primary care shortage areas. You have to be in one to get one of those status. Now here, I want to ask a question before I show this next slide. What do you think the percentage of people are that have fast, high-speed internet and a computer to operate it at home in Illinois? Guess what percentage would you think? 50. That's a really good guess. It's exactly right. 58%. Now, this is actually a little higher than a lot of places. 58%. So I want you to think about something. How do you go apply for something, a job, or anything else if you go home and you don't have the internet? Are there paper applications anymore? How about if you're having to go prove that you're working to get Medicaid? Where do you think that application is? Online. So only 58%. Now, do you think it's the Medicaid households maybe that have? No, of course, they're the ones that don't have largely internet at home. So that's an enormously important statistic. And during the previous administration, there was a big effort to fund fiber optic expansion, internet expansion. It's a utility now, and that is no longer a priority. 16% of children are in poverty in our county. We have a very wealthy county. In our district, I should say. Monroe County, we're lucky because we're a pretty wealthy county, but those around us are not so. And then 18.3 teen births per 1,000 females, average of, what's our average? I think that's 18.3%, excuse me. So I'm screwing that up. But compared to the national average is 13.5. I think that stat's a little messed up. And I got all these stats off this Congressional dashboard. Okay. If you go to certain politicians' offices, and I won't name any names or use any partisan labels, but an enormous part of the response I get is, hey, if you just kick, and I will not use the term I will use is undocumented immigrants. If you just kick all the undocumented people off, insert different language, all these cuts will pay for themselves. Well, no, it's not true. Undocumented people do not have access, as Chastity was talking about. They have emergency access. So all of the conversation about, hey, well, just go to the emergency room if you're sick is just wrong-headed at best. So undocumented immigrants do not have access to federally funded benefits of any kind. That is a fallacy and is an argument made to justify a position which is baseless. They may qualify if we have certain types of protected status, lawfully present immigrants, or qualified immigration status. And of course, what are we trying to do? Go after all the people that have qualified status here. These are the folks that can get federal benefits. If an undocumented person shows up to a community health center, the community health center is obligated to see that patient regardless of their ability to pay. Just like an acronym EMTALA, which is emergency medical, whatever TALA is, that requires people, the hospital, to see a patient in an emergency situation. Now, our critical access hospitals are required. They have 72 hours to keep a patient. You keep the patient for 72 hours, you get them stable, you ship them out. That is a requirement of the program of critical access hospitals. So there's some emergency care that's available, but folks that are not here on a qualified status cannot get Medicaid. So that argument, do not accept that argument from people. It's untrue. I have to sit on my mouth, sit on my hands. I have to put my fist in my mouth when I'm in a politician's office and they start saying this to me. Now, you can tell I'm probably not the most conservative guy in the world. But I work in an extremely conservative industry. You know, we're all in rural areas, so you got to be really careful. And we're trying to have reasonable conversations with very conservative politicians, so I can't just get all emotional about it. But these are facts. This is not conjecture. Let's talk about the Affordable Care Act. First of all, why can't an alternative be found? Why have we been struggling? Oh, 2 weeks. 2 weeks. I have a plan in 2 weeks. 2 weeks. I have a plan in 2 weeks. Why can't we come up with a plan? Because Obamacare was a Republican plan. Mitt Romney came up with it. That's why it was such kind of a genius move politically for President Obama to co-opt the Republican plan. And it's left them flailing in a lot of ways ever since. It had two big objectives. We expanded Medicaid. So when we hear about Medicaid expansion, that's Obamacare. We increased the number of people eligible for Medicaid. And now we're trying to roll it back. The second thing it did is it created healthcare exchanges for people that are not qualified for Medicaid. They're probably employed in a small business or they own a small business, and their small business does not offer affordable health care. So we get these healthcare exchanges for people that are not covered by an employer plan. So here's Medicaid expansion. We got up to 138% of the federal poverty level, which, wow, seems generous, right? But try living on $15,000 a year. Try living on that. So first we expanded the ACA. Medicaid, prior to the ACA, was funded approximately, call it 50-50, state and federal funds. And one of the big Supreme Court cases that we got said, no, states can opt into expansion or not. So then we got this whole patchwork of states that chose expansion and states that did not. And so those states that chose expansion, the government, federal government, pays up to 70% of Medicaid funding. And some states go up to 90%. And all of the states that are having massive hospital closure issues are those that did not expand Medicaid. Funny how that goes together. Not really. States on their portion of the funding are permitted to finance the non-federal share of Medicaid from other sources, including state funds, dirty word, and provider taxes. So why do you think there's been such an effort to kill Obamacare? Because it's funded by a tax. Funded by a tax. Keep that in mind. I was a huge proponent of Obamacare because I am a hypochondriac. And I was worried about something like happened to you, happening to me when my kids were small, and then I was going to die, and then my kids wouldn't remember me. And I just would catastrophize. And so when Obamacare came along, remember what all Obamacare did. Created exchange markets, requires employers to offer affordable coverage, and include several consumer protections that we would think would be taken for granted but are not. New regulations, so we have new taxes, we have new regulations, which are, of course, very dirty words in some circles, right? What did those do? First, it prohibits health plans from dropping you when you get sick, rescinding your coverage when you got a cancer diagnosis. Sorry, you don't have an insurance anymore. That was rescission, and Obamacare made that illegal. Requires employers to not offer affordable coverage to pay penalties with some exceptions. Prohibits lifetime coverage limits. My daughter has a condition that she's going to be an expensive person to cover, and now they can't kick her off when her cost of coverage exceeds $1 million. But what does the future hold? Good question. Rebates to enrollees and businesses if your large commercial health plan does not spend an appropriate ratio on covering care and has higher administrative / CEO salary costs. They pay, some of us got rebate checks when, I won't mention the insurance company's names, but they have too high of administrative costs and they have to pay rebates back to insured people. It's a big deal. And then that's where we get also, remember, our kids can now keep their coverage to age 26, which has been a lifesaver for many. Health care exchanges, we've heard the term subsidies a lot in the past several weeks, haven't we? And that's what's going away. That's why right now we're about to have, maybe not a healthcare Armageddon, but if I'm a person on a subsidized plan and my subsidy's gone away and all of a sudden my monthly premium is going up by $4,000, if you're in a certain actuarial age bracket, which I'm close to, you're going to be more expensive to cover and you're going to have excessive increases in your premiums. And this is where these subsidies come in they subsidize those health plans to make them affordable. Now, here's a huge downside. Do you know the only reason the ACA passed? I was following it very closely. I've been a news junkie since about 1973 when Give 'Em Hell Harry came out, and I was a little kid. And for some reason, that movie really turned me on. And I've been a political junkie ever since and watched Obamacare closely. What happened in Obamacare? The law was written in the House, and it took away health insurance companies' ability to be monopolies. The bill went to the Senate. In the Senate version, the only reason health insurance companies signed on is because that antitrust provision went back in. Who gets antitrust protection? Public health utilities, Major League Baseball. Health insurance companies. So one negative outcome of the ACA has been legalized, this is the only way we got it passed, legalized health care monopolies. That's why we have 2 or 3 big players in every state. And it's genius, too, because now you've got to go deal with 50 different state laws to address it. But this is one thing we're suffering from now. This is why you see a lot of hospitals that run into problems with whoever they have a contract with, one of the two big payers, and they remove that contract, but then the patients suffer. So this is a big negative outcome of ACA. Another, in my view, very negative outcome of ACA was the fact that physicians commoditized themselves. We took the power away from the physicians, because what happens is all the physician practices around you started getting bought up so that healthcare entities could scale, and we've wiped out independent physician practices. We're compounded by a problem in Illinois where our rural health clinics have a pay scale based on a year 2000 consumer price index. So relative to the rest of the country, our rural health clinics get about 60 cents on the dollar relative to rural health clinics in Missouri, Kentucky, Texas, Tennessee, other places. So we've got a compounding problem that were some negative consequences of the ACA. Now let's talk about this ridiculously named legislation. One big beautiful bill. First of all, it established work requirements which have been a proven failure. Because what happens? The paperwork is confusing. The paperwork is difficult for a lot of educated, knowledgeable, well-read people to fill out, and often it just really trips up Medicaid recipients. So we've established work requirements. We're exempting the work requirements for those who are frail or disabled. We're verifying, let's see, we have to, if the person hasn't met the work requirements for the previous 3 months, they will lose their insurance. We will disenroll people that don't meet the work requirement. We prohibit these provisions from being waived. So where states had power over their Medicaid programs, now we don't. We are exempting states from compliance with this until 2028. That's good news. That is good news. Hold that thought. On work requirements, we may have one time a year that we have to prove that we're eligible because we meet the work requirement. Remember, we saw 70% of our recipients are working, but now we've moved this to every 6 months. The Georgia model has seen a significant reduction in Medicaid recipients because people can't fill out the work requirement paperwork. And what happens if you don't have internet at home? What happens when you don't have internet at home? You're going to lose your Medicaid coverage. You're just going to give up, is what has happened. FMAP. Healthcare, if you ever get involved in healthcare, you know we have an alphabet soup of acronyms. You got to learn all these acronyms just to stay current. And FMAP is the federal matching dollars that comes for funding Medicaid expansion. So one big beautiful bill eliminates FMAP. So that federal matching dollar that gets us to fund 90% of our Medicaid expansion, now we're going to drop back down to 50%, and states are individually going to have to come up with a funding mechanism for the rest of their Medicaid. So what are the states going to do? Cut. That's exactly right. We know that will happen. That will be the outcome of this FMAP. Largest reduces provider taxes. So not only do we eliminate the matching dollars, but we prohibit states from enacting provider taxes. So all of this talk about defunding, eliminating Obamacare, we're achieving that through the back door because we're cutting off all the mechanisms that make it work. That's the point. That is the point. Reduces the payments that require managed care organizations to make to healthcare providers. So we're removing a lot of those regulations that made the ACA a success. These tax credits removes the tax credits. So we as individuals, if you're on a healthcare exchange product and you're paying a certain amount of money, this is why it's gotten so expensive, because we would get a tax credit if I have to pay for those plans. And now the tax credit, the subsidy's going away, the tax credit's going away. So we've both directions making it more expensive to have healthcare if we're on one of those exchange products. So this is from KFF. There is no extension to the tax credits, and the number of uninsured people will rise by 4.2 million. One statistic I did not have in this is that one big balanced, one big beautiful bill represents a $880 billion cut to Medicaid over 10 years. In my book, that's a lot like $1 trillion. $880 billion cut. We'll have some other fancy stuff that none of us have access to. So, approximately 66 million people, 20% of our population, live in rural areas, and 25% of our adults are covered. And we cover nearly half, Medicaid covers half of all births. And so that's going to get wiped out when you have fewer Medicaid recipients. $137 billion our Medicaid spending will be reduced by. So all those critical access hospitals that rely on Medicaid populations, guess what? They're still going to see the patients. They're just not going to get paid for it. But ultimately, we will lose hospitals at an accelerated rate because of this. All rural hospitals, I can tell you, are deeply concerned about this. Now, there was a listing a few months ago about at-risk hospitals or hospitals are about to close in Illinois. And I can tell you a lot of the hospitals on that list were upset that they were on the list because it was not a super accurate reflection of all those hospitals' conditions. But those same hospitals only have a 1% margin. So any change, any reduction of their reimbursement, take a bunch of their Medicaid reimbursement out of it, and it will definitely accelerate hospital closure. So here's how we impact rural. 2.8 million Americans rely on plans purchased through the marketplace. Expiration of these subsidies will increase premiums by an average of 107%. And individuals are going to forego coverage. We've seen this before. This is why we had the ACA, because we had such large populations of uninsured people in the richest country on the planet. 350,000 jobs. 350,000 healthcare jobs are at risk. And phantom enrollees subsidizing health insurers were going to cost $380 billion. $380 billion. So we have this Rural Transformation Fund. We're supposed to get $50 billion to rural providers. We just had this huge application process, and we've all applied it. But guess what's the one thing we can't use the Rural Health Transformation Fund for? Making up Medicaid dollars. We can upgrade our software, we can participate in value-based care, we can start care management programs, but we can't replace Medicaid money with this. And $50 billion is less than half of the reduction we're going to see just in rural areas. This is just in rural areas. This does not include the healthcare desert we have in a lot of our urban areas. My office is in Soulard, and I look right out at some of the biggest healthcare deserts. I just go down Grand. And so this is just in rural areas that this is this impact. So $50 billion is helpful It's not a small amount of money, but it also doesn't solve the problem. It's a political patch to say we're trying to do something. Now, here's the stalking horse. Sequestration right now is at 2%. It is based on the deficit. Medicare has a provision because of the increase in the deficit that is projected to occur because of one big beautiful bill. We're going to see an additional 4%. So it's going to be a 6% sequestration cut based on the increase in the deficit because we have this law called pay-go. You got to pay as you go. You got to pay as you go. Now, here's the thing. A lot of these provisions don't kick in until after the election. Now, that's a cynical political move, but it's also a big opportunity because these cuts will not take place for a couple of years. We're going to see, we already see right now immediately, the healthcare exchange prices of our premiums are increasing starting January. But all these Medicaid cuts don't kick in for a couple of years. So it provides us an opportunity. Here's this is the timeline. You can all look at this. It's all on KFF. Just go to all these acronyms. OBBB timeline. And you'll get this KFF document. That's the implementation. So I do a lot of lobbying. I have a trip I'm taking in February and then another that my company is sponsoring in June, specifically focused on rural health, where a bunch of us from around the country convene on Washington and we go all visit our reps. I had one of the craziest conversations I've had ever in, I won't name the rep, but they're from Alabama, and with the chief of staff, and he said to me, I brought up the Medicare sequestration problem. We were having a friendly conversation, then I brought up the pay-go 4%, and the dark shroud came down on his face. And he said, you know what? The problem is we just purchase healthcare all wrong in this country. I said, okay, so tell me. I'm sure you have some ideas on how that should happen. So he says to me, first of all, we got to kick all these lazy people off of Medicaid. Kick all the able-bodied people that can go out and get a job, kick them off Medicaid because they shouldn't be on Medicaid. And we need to kick off all the undocumented off of Medicaid. And that's going to pay for a big chunk of this, first of all, first. Then we're going to have price transparency. So a lot of us have seen the surprise medical bill thing. It's a total fallacy, and it does not reflect how healthcare gets paid because your prices are increased everywhere you go so that I price everything so every payer I have, all my commercial payers and everybody else, I'm going to be over what they're going to pay me so I don't take any cuts. So I'm going to price myself at $200 because I have a commercial plan that pays me $195. I have a lot of other plans that may pay me less, but that's why we have such dramatic price inflation for healthcare. So price transparency isn't going to get you there. But this guy says, well, if you have price transparency and I need a heart transplant, there's one guy and he has it posted on his wall and he says the heart transplant's going to cost $12,000. And then you have another guy and he's going to do the same transplant for $45,000. So, of course, everybody's going to go to the $12,000, and the other guy's going to have to lower his prices. And I thought, well, first of all, no, I don't think I want the bargain discount heart transplant, A. And B, that is not how any of this works. So it just demonstrated vast ignorance on how this works. But this is what we get. So then between kicking all the able-bodied people off of Medicaid and price transparency, Then we're going to have HSA, health savings accounts. And then your insurance should only be catastrophic insurance if you get cancer or get in a car accident, and everything else is out of pocket. And I thought, dude, okay, I'm just need to move on to the next office here because we're two totally different planets from one another. But that's where one side of the argument is made. And then strengthen Medicare Advantage, which means what? Increasing private for-profit health care. And then we're going to do that by defunding Obamacare. So this is kind of one side of the argument here that I personally, I'll speak for myself, think is a fool's errand. Now, when we talk about our Democratic responses, we see we just want to get back to the status quo. Fully fund Obamacare, strengthen our Medicaid and our insurance exchanges. So these are kind of the two flavors of the conversation that are happening. And we're not having a lot of compromise for folks anymore. So that's where we are right now. So right now we have an opportunity to change the conversation before these cuts happen. And it's going to take us and people like these rooms to talk to our legislators and say, hey, that is not what we need. Go express yourselves. I won't put words in your mouth. But so there you go. Universal health care. Yes, Medicare for all. I don't think any of us in this room will see it in our lifetime. I think, yes, that's where we need to go, but I don't think it's a realistic outcome for us because 25% of our GDP are healthcare dollars.
Unless we move to any other industrialized country in the world.
And my niece in Australia has Medicare for all. She had an overnight stay in the hospital, an elaborate scan. It cost her $300, and she wasn't even covered yet.
But the people that go on these cruises and stuff, they go overseas, if they have to go into a hospital, I think they said, one person said their bill was $100.
$100. Now, so that's true. Here's my personal thought. This is Charles James speaking, not my company, nobody else. Medicare works great. Medicare is an efficient, inexpensive insurer. My personal thought is we eliminate the healthcare exchanges and we open Medicare up for 50 and above. And you get all the people on these now subsidized plans and get them on Medicare. Everybody pays for Medicare Part B. We pay for Medicare Part B. And those premiums will go a long way. And theoretically, 50 to 65-year-olds are less expensive to insure than the 65 plus. We spend about 50% of our Medicare dollars in the last 6 weeks of a patient's life. So my personal hope, I would love to see universal health care. I don't think it's a realistic goal for any of us in this room to see, but I think we can move towards that. So first, let's get this current crisis resolved. We just saw what happened in elections 2 weeks ago when we put our minds to it. Politicians do listen to us. So we have a big push now, between now and just after the midterms, when the next election takes place, to change this curve. We can still change it. All we need is legislators that will vote on a reasonable bill. So there's hope. We're in a crisis situation. We have time to resolve it. And we have to decide where we want to put our healthcare dollars. I think it's expanded Medicare. I don't hear anybody talking about that. So believe me, my little voice doesn't get very far. But that's what I would like to see. That's what I would like to see. So that's the one big beautiful bill and what we're looking at. A massive, if this goes into effect as is, which I don't think it will, personally. I think we'll get some changes made to it. but we're going to have to work really hard to do that. But if this status quo stays, we will have a healthcare Armageddon. We're gearing up for that. And it's up to all of us to change that curve. Yes, sir.
Those of us who are on private plans or employers or whatever, are our costs going to go up too? when
Absolutely.
exchanges blow up?
Absolutely.
We just got ours.
You just got yours.
Yeah, ours went up $310 per paycheck, so twice.
Per paycheck.
Mine
On
just
private
went up
insurance.
30% from last year on my employer.
It's going to affect every commercial health plan out there. Yes.
I'll tell you where it's really bad, and I can justify that from I'm aging myself back in the late 70s when a lot of people were laid off of work. And that's when they started that if you lost your job, they had this other plan.
Oh, no.
But it was like, do you pay $700 a month to give health care to your family, or do you pay your mortgage?
And now that $700 is probably
And you're
$2,000.
only getting $300 in unemployment. So where does the money come from? Yeah. And I can remember the day when, like you said, when you're unemployed, you're kicked off of all your benefits.
Right.
And then if you started a new job, they held back your benefits for 3 months.
Mhm.
And then you were entitled to benefits. And then if you were pre-existing on anything, they didn't have to insure you.
And I didn't talk about the pre-existing conditions at all, but yeah, you could just not get insurance
Yeah.
in the first place. Our
Yeah.
daughter would be uninsurable.
Yeah, and that happened a lot.
Happened a lot.
Or a sick kid hits their limit by the time they're, 18.
20, yeah.
Yeah.
Absolutely. And it happens, we have chronic illnesses.
Yeah.
And the
It's a
price of
fact of life.
everything's going up, so.
Price of everything, and healthcare inflation
Oh, it's
is
nuts.
drastically surpasses just regular inflation in the rest of the economy. Well, thank you very much for listening. I appreciate it. Thank you.
All right. I don't know about you, but I have several questions that I'll be wanting to ask them. We do have one more speaker, plus we'd like to give Julie some time. So if you do have some questions, just hold on to them, and we will try to get some time at the end. But one question I want to have is Mr. James, how he has an unemotional conversation with... You might need to give a session on that, how to. Okay, I don't know if I can do that, but all right. Kathleen, thank you for the tip on Mr. James too. Appreciate that. Okay, so we do have one more speaker that I'd like to introduce. We didn't know she was going to make it tonight. She did. She's very busy, but she's amazing. I heard her speak, 10 years ago, maybe. But this is Dr. Pam Gronemeyer. She is a member of the PNHP, which is Physicians for a National Health Program. She's co-president of PNHP Illinois, the Southern Division, board member of Missourians for Single Payer, and vice president of the Illinois Single Payer Coalition Board. She is a board-certified anatomic and clinical pathologist. She received a bachelor's degree from Washington University in St. Louis, attended Tufts University School of Medicine, and completed her pathology residencies at New England Deaconess Hospital in Boston, Barnes Jewish Hospital of St. Louis, and St. Louis University Hospitals. Dr. Gronemeyer is the director and a woman small business owner of SEMC Pathology, LLC, in Highland, Illinois, a pathology business that provides services to 6 critical access hospitals, as we've learned about in Mr. James' talk, in southwestern Illinois, St. Joseph's Hospital in Highland, Redbud Regional Hospital in Redbud, Washington County Hospital in Nashville, Pinckneyville Community Hospital, Pinckneyville, Marshall Browning Hospital in DuQuoin, and Community Memorial Hospital in Staunton. She's actively involved in directing the Infection Control Committee in the hospitals, as well as working on quality assurance activities and advocating for patient safety. She believes health care is a human right and provides health care insurance to her employees and their dependents. She's an activist in her community and in the healthcare arena. And as the child of a late union laborer, she knows that our safety net is vital to the preservation of our democracy. So I think following Mr. James, she's going to have some good things to tell us. So, Dr. Gronemeyer.
Oh, I am also at El Dorado, Farrell and El Dorado, and Hardin, which is down by in Belclair. Okay, now I'm a good to follow him because I am a physician for a national health program, and I believe Medicare for all will work. I mean, there are 18,000 of us people, our doctors and nurses and other healthcare providers who believe it will work. And we have a meeting every year in November where we talk about it. We just need to spread the word because people don't know what it means. You know, when you talk about single payer Medicare for all, they don't realize that it will pay for itself. I mean, it will remove the insurance companies, but the insurance companies, they make money off of even administrative services. Medicare is administrated at like 2 to 3%. Insurance companies are probably 15 to 20%. So we can save money, and if you look, there's a bunch of articles about how we finance it, and also the Congressional Budget Office said it would work. So therefore, what we need to do is spread the word and explain it to people. So, okay, well, and I agree almost everything with Mr. James said. I'm going to start out with the problems with Medicare Advantage. Medicare Advantage looks wonderful because it has a low premium and sometimes no deductibles. And sometimes you don't have to pay anything for a premium. But believe me, it's not perfect. And most doctors will I don't take Medicare Advantage because I don't think it doesn't work. Because first of all, the insurance companies are benefiting from Medicare Advantage. And they also make you have you have to have pre-approval, which means unlike Medicare, I don't know if you think that people love to go to the doctors, but I'm over 70, and I don't love to go to the doctors, and I don't think most Medicare recipients are just dying to go to the doctor. So I don't think we overutilize it. But Medicare Advantage you have to have a pre-approval. The way they rate people in Medicare Advantage is incredible. They go through your whole medical record, and they find any possible problems you might have had as a stub toe or whatever, and they add that to your risk. So by raising the risk of the person, they raise the amount of money they get every month because they're paid per capita. They're paid per capita so much per month for each of the patients. So, they're clearly, their idea, if you don't get health care, if you don't, they save the money. And that's the problem. They don't give the health care they need. You're fine if you're well, and it's a low premium, I agree, and that looks beautiful. But if you get sick, you don't get you may get denied your cancer care, you may get denied your surgery or whatever. And also it's telling that they don't use most of the highly rated medical centers. You can't, in New York City, you can't go to Sloan Kettering for cancer care because it's not on their providers list. They take it away from the centers of excellence. They don't contract with them. So therefore, you can't go to the places. You can't pick like Medicare. You can pick where you want to go, and it's not true that most doctors don't take Medicare. We realize that. I'm a physician. I'm a pathologist. I know there's not an unlimited amount of money to pay for medical care. So I have to make my prices. I like he said, you set your price at something, knowing that what Medicare's rate is. Medicare's rate doesn't change very much. And most insurance companies are based on Medicare rates. So the problem with Medicare Advantage is it sounds good, but it isn't good. And most doctors won't go on it. The other thing is if you go on Medicare Advantage and you want to drop it, if you want it, because what I do, I have it's costly because I have to have supplemental from Blue Cross Blue Shield. But when I went on to it immediately, when I was Medicare age, I didn't have to fill out any healthcare thing telling my problems. But if you drop Medicare Advantage and you go to conventional Medicare, you do. And then the insurance companies can deny you care or they rate you. So therefore, there are some reasons why not to do it. But Medicare works. I mean, I had bilateral mastectomies and cancer care, and I have my supplement, and it works. I mean, I didn't have any choice. I went to Barnes. I went to Siteman where I wanted to go. So Medicare, I mean, and this theory about turning everything to Medicare Advantage, the insurance companies are making off like bandits with Medicare Advantage. If you look at the profits, how much money they make off of Medicare Advantage, I mean, it's terrible. So therefore, we're negative Medicare Advantage, the Physicians for a National Health Program. The second thing we're also negative is about the corporatization of medical, about how much 60% of doctors are owned by corporations or hospitals. And that's dangerous because what happens is, even if they have an opinion about Medicare Advantage or Medicare for All, they can't express themselves because they'll be sat on by their employers. So therefore, you know, would like to keep as many doctors out of corporate medicine, I mean, as we could, because it's just not, we don't want doctors to be corporatists. The problem is that it's expensive to run a practice. So the next thing is about and I can't call it the one big beautiful bill. I have to call it the one big terrible bill. I mean, because it's terrible. I mean, it's cutting money out of, well, Medicaid. And then you talked about, and it is in the Kaiser, I like the Kaiser Family Foundation because they do give you a lot of good information. I mean, I look at face sheets for people who are on Medicaid. They don't not work. They work for fast foods. They work for a nursing home. They work for places that do not provide insurance. And I'm a small business owner. I have a private standing lab in Highland, Illinois, and I have 5 employees. My 5 employees cost me $6,600 a month for health care insurance because I pay all their premiums. And then we have as low a deductible as we can. If they go over over $500, I try to give them $500 more. So I think, you know, my employees are my best, you know, they make my business. So therefore, I think health care is important. But it's expensive, and it went up again, I think it went up 6% or something again because it keeps going up. So, I mean, it's not, I mean, if they cut everybody off of Medicaid, like they want to after the next election, or, well, they say by 2034 they're going to cut them all off. And, I mean, to believe that they're shiftless and lazy is baloney. And also, that stuff about, we know that people that are undocumented can't get health care, Medicaid. So that is just baloney. I mean, and they should be, you know, if their noses were growing, they wouldn't fit in the door. Because it's just, I mean, it's ridiculous. So we know that it doesn't make any sense. And now the other thing added on top of that is this ACA thing. And we don't know how many people are going to go off the ACA. I mean, people are predicting that their premiums are going to go up 600%, which is like terrible. So they're not going to have health insurance. And I mean, the small businesses really cannot afford health insurance. I mean, it really takes me a lot. I mean, I tell people if I do private autopsies or whatever, I'm a pathologist, I do those to make money to pay for my employees' insurance because I think it's a value for them to have health insurance because I want healthy employees. And I mean, also, we want healthy people in the country. So health care should be a human right, and we should all work for it, but we need to keep pushing and pushing. And I mean, I myself would like to see single-payer health care in my lifetime, but I think we should make it our moonshot. Kennedy made it a moonshot in the 60s that we would make it to the moon. Well, why can't we do this for people? I mean, would we join every other industrialized country in the world? I mean, not all of them have exactly Medicare for all. I mean, Germany has a different system. Canada does, but they do pay more taxes, but you get something for your taxes. I mean, in the way Medicare for all would work, you would pay an increase in your taxes, but that would cover what you're paying now for your co-pays and deductibles. I still believe I should pay my employer's tax, so I would pay that, but that would be a lot less than I'm paying now. And we would cut out the insurance companies. And, you know, it's ridiculous. I mean, no offense to the insurance companies. They don't add a whole hell of a lot. I mean, basically, they're to make money. And, I mean, now what's happening at some of the hospitals, United Healthcare has cut the fees so much that the hospitals want to drop them. So, I mean, it's like And then, I mean, talking about rural hospitals, we don't know how many rural hospitals. I think they said like 9 rural hospitals could close in Illinois. And the 2 nearest ones are Benton and Hardin, which is in right on the the Illinois-Kentucky border. So they could close, but there were some more up north. But we can't afford to lose the rural hospitals because people will have to go a lot farther for their medical care. I mean, in those critical minutes when you have a heart attack, you need to get where you're going. I mean, they dropped OB because you have to have enough OB service to have 2 OBs. You can't have 1 OB because you have to have coverage. So that's partly why Redbud dropped them. You know, Redbud had an OB service, but it was they couldn't afford to have 2 providers. And you can't get like a per diem to come in every other week. So, I mean, rural hospitals and people in nursing homes, what's going to happen to them? I mean, what's going to happen? They're going to have to fall. Their families are going to have to take care of them. When when families take care of you, you have someone to take care of at home. You may have to give up your job. You have to provide. I mean, it's just ridiculous. Nursing homes will close and rural hospitals will close. And we can't afford to let that happen. And like I said, the ACA, that also is going to take money away from people who are now getting health insurance on the ACA. So that's going to drop the number of people also who are eligible or will go to rural hospitals. And rural hospitals the problem with them is lots of the private insurance companies will pay rural hospitals less than they pay metropolitan hospitals, which is not good either. I mean, let's face it. And we know Medicare's set up to pay on your diagnosis. But in critical access hospitals, it's not set up on your diagnosis. It's set up on fee-for-service. So therefore, that's why they can function. But it's just going to, I mean, I can't even imagine the Armageddon. That's why I think we now should push for single payer. And Bernie pushed for it. And there are Republicans that, you know, there was an article in one of the cardiology journals about it. Cardiologists from Texas, and cardiologists are one of the big paid doctors. And he was for Medicare for all because he realized that's the only way to go. And, you know, as a doctor, we take an oath to do no harm. We're supposed to take care of people and try to make them well. Well, we can't make them well if they can't get in, or we can't get them into the hospital. We can't get them anywhere. So we are looking at an Armageddon. I mean, he's right. It's an Armageddon of what could happen. And I don't even know what's going to happen after this. How bad it's going to be with the ACA when they cut the subsidies out. And I mean, clearly they're not going to do anything about the subsidies. I mean, they've already said they're not. I mean, they said they would theoretically, the Republicans said they theoretically would rethink it, but I think they've already retracted that.
They'll have a vote.
They won't do it now.
And Trump thinks what you should do is give people money for their health care. It's like, what is he talking about? He doesn't have any idea. And, you know, that $50 billion that they put in the one terrible bill, that's not going to go very far because that $50 billion for rural hospitals has to be divided by all the states and over so many years. So it's not going to amount to what they're losing now. So, I mean, we really are looking at a disaster. So we need to go to our congressmen, our senators, and, you know, I'm mad at Durbin because he voted to give up the vote for the work for the ACA. But we need to push and push now. And I mean, if you want to look at a site, his Kaiser Family Foundation is great, but you can also go to the Physicians for National Health Program, which has a good website too and has information. And I mean, you know, if anything that I can do, and that's why I came down here tonight. I was had to squeeze you guys in, but I think that we need. You know, like I said, I wanted to make it my moonshot. That may sound like a wacko, but I remember we never got to the moon until after Kennedy made it our moonshot. So really, we should aim for it. And I mean, now is the time. If everything else is going to fall to pieces, we need to push it. So, anybody have any questions?
Yeah. Question for you, the doctor, because we're talking about insurance company. Can you give an estimate of the number of staff hours in your office that are devoted to processing insurance claims and arguing with insurance companies?
Well, I have a full-time biller, but she works 20 hours a week. And I'm a pathologist, and I I'm trying to think. I don't know. I mean, I probably have about 3,000 surgicals a year. So she's 20 hours a week. So that's a pretty costly too. I mean, you don't have to call for me because I don't have to get pre-approval. Because I get the specimens when they're taken out in surgery, the doctor's office. But if you get pre-approval, I mean, I've heard of doctors calling for pre-approval, and they told the guy he has the wrong number, so he has to call back again after. It's like, oh my, they do everything to try to discourage you from doing it. And the other thing is bad with Medicare. Medicare has an act called the Wiser Act. Now they want to start trying to have pre-approval for our Medicare claims, and they're going to use AI. Isn't that wonderful? Artificial intelligence. Doesn't that make you feel good that some machine's going to decide? I mean, right now, a lot of your decisions are made by nurses. You can't even get to a doctor to tell them. So therefore, AI, I can't even imagine. But they're going to try that, I think, in 5 states I saw that they were going to try it. But we don't know what, that because they're trying always to reduce Medicare. They want to, and Medicare works. Anybody who's on Medicare should tell people it works. I mean, that's the other thing, that people over 65 need to tell everybody how well it works.
I went to a doctor over in St. Louis. They have their own clinic there. Mm-hmm. And I had gotten the most exceptional feedback all the time, constantly, and care was wonderful from the nurses on up. Every time I went in there, everybody was happy. You could see, and I asked the nurse one time, why is everybody so happy here? And I mean, the doctor would always take time and come in and look and check my knees. I had my knees done and that. And they said was because these big businesses don't own us.
Right. Oh, right. Yeah, that's right. They don't want to be owned by corporations.
We are self-owned clinic here, and that is why. And so when he does his surgery, and they said you have to have 15 minutes per each patient or whatever, he says I take my time, and if they don't like it, it's their
half
problem.
the time somebody is looking at the board to type in your stuff. And the other thing people have, this wonderful thing about the electronic medical record. You know why they wanted the electronic medical record? To capture all the billing. It's not really to make it any easier for people. It's so they capture all the billing. I mean, if you look at ER records, they charge by how many minutes of critical care they give. And the same thing in the hospitalists. They write at the bottom how many minutes they spend. As a pathologist, I have a published fee schedule. I mean, I'm not overly happy that they pay me $35 to diagnose cancer in a breast. And I would say it's harder because it took me a while to learn. And I tell people that the cells don't have C's on them, so I'll know they're cancer. Or they don't have M's. Well, no, I mean, I have to spend time. But what they did, they came up with a fee schedule that they theoretically spend how much time you spend on it, how much expertise you need, and how much. There was another thing, I guess, that you did that was the fees that was that produced their billing, and it was like part of a PhD dissertation paper was how they arrived at it. But I mean, we have to have some way to set prices. So I mean, like I said, I know that there's not unlimited money. And I mean, it will be better if we do Medicare for all. But I encourage you guys to look at PNHP or to look under, like Gerald Friedman is a guy who wrote a lot of articles about how we fund Medicare for all. And Bernie Sanders had a lot of information about. I mean, it will work. I mean, if people weren't if they wouldn't keep telling us it's socialized medicine, and it's socialized medicine, no, it would get better quality and would get the friggin' insurance companies out of it. And I mean, I'm sorry to the insurance companies, but I don't think they add any great benefit.
As Americans, we get told over and over and over again that we have the best health care in the world. We have the best.
He's right, 37th.
Yeah.
We're 37th.
Yeah, and when you look at the mortality rates for OBGYN, we're
it's
the
terrible.
worst in the world.
It's terrible.
It's like,
and this is the first time in the last 3 years where our life expectancy has gone down, especially among people like the black population and among people that are poorer. it's gone down. But even among the regular people, it's gone down. So isn't it telling?
That, but actually, black people, your life expectancy, depending on the zip code you live in.
Oh,
be-
determines it, right?
Yeah.
Determines it. So yeah, no. If anybody have any questions, but yeah.
I saw or heard that the AMA has typically been against any type of single payer. Do you have any insight into that?
No, I wrote them, and I belong to the AMA. But I went to an AMA meeting, and there are a lot of people that are for it. But you've got so many doctors that are entrenched in what they believe in. It's like the Illinois Medical Society. It's like talking to a brick wall. What we need to do is find the people that want to push it, and a lot of the younger physicians do want to push it. So we need to, we need to keep harping on them, telling them why it makes sense, and they need to look at the data. I mean, we're not talking about them reducing how much money they make. And I mean, realistically, anybody who goes into medicine just purely to make money is wrong. I mean, it's not, you got to work hard, and it's not going to, I don't think you're going to be a billionaire. I mean, maybe a neurosurgeon is, but I don't think so. But it'd be pretty depressing to be a neurosurgeon. So, okay, thank you.
Thank you very much. All right. So we're going a little long. We got about 5 minutes till 9, and we'd like to get Julie up here to introduce herself. And then if anybody wants to stay for questions, we're happy to do that. Hi, Julie.
I think most of you've met me. I see a lot of familiar faces in the audience. I see some people that I saw again last night. My name is Julie Fortier, and I am running to unseat Mike Bost. If you don't know, to give you some background on myself, I am an Air Force veteran. I served 4 years in the United States Air Force. I'm sorry. I usually walk around, Paul. Then I'll trip. I spent 4 years in the Air Force. I was in communications. I did computer work. I tell people that when I lived in Germany, my stuff stayed there, and I traveled. You would commonly find me working and living out of a tent near a runway. I spent 4.5 months in Desert Shield, 2 days in Desert Storm, and then they shipped me back for an emergency at home. And then I got stationed at Scott Air Force Base in 1991, and I have been here ever since. I worked full-time to complete my bachelor's in both math and biology. I do know what it's like to work hard to get the job done. I've worked for wages. I've worked for tips. I've worked for overtime, and I've relied on overtime at times to really help my income. So I understand what that's like, despite what Bost seems to think the big, beautiful bill will help us with that. I have been without insurance before, like many of you probably have. I will tell you, the people that designed this bill have not. They don't know what it's like to have the fear that you will not be covered. And I was young. I mean, nobody would think you would get sick, but I was afraid of getting in any kind of car accident and that insurance wouldn't cover it. So I actually got insurance through my employer. I spent 1/3 to 1/4 of my entire month's income on my insurance. And it still wasn't great coverage, but at least I had coverage. Until Obamacare came out, I was horrified with having any kind of pre-existing condition. As all of us get older, things are found out, things are discovered. And since that came out, when that came out, I was like, I can actually switch insurances. Because my husband and I were talking, I'm like, you can't quit your job yet. He didn't like his job. I'm like, no, because we can't have a different insurance yet. I can't afford not to be insured. He still stayed with me. And Obamacare came out and it helped that. And now I was listening to a bill today. There is a podcast I listen to. She is a breast reconstructive surgeon. There is a bill coming out that is on the floor soon. I have to figure out when it's going to be signed, and I'm going to see how Bost signs it. And I don't know if you're aware of this, but it limits what a reconstructive surgeon is allowed to do for a woman, and it benefits the insurance company. I was horrified. People don't realize, the people that signed this bill, I don't care if you're a man or woman or what race you were, if you sign this bill, you don't know what it's like. You don't know what it's like to have a cancer scare. You don't know what it's like to be sitting in a robe wondering if they're going to come back in the room, is it good or is it not? Is it your first biopsy, your third biopsy? It's horrifying. And then to think that you're not going to be insured or not going to be covered, or if you have to have, God forbid, like you have treatment, that the insurance company can go to substandard or go to practices that were done 10 years ago because it's cheaper. It's not okay. I'm sorry, what? Oh. So I will tell you that a vote for me, people have said, stop saying you'll fight for me, but for insurance, for medical insurance, it will be a fight. But it is not a fight I am actually willing to give up. It is a fight that everybody in my family has had to endure, and I would love to use Charles as a resource, because you seem to be a wealth of information, and some of our data is different, so I want to make sure that I have the correct data, because facts, I have a PhD in biomedical science. I only rely on facts. Those are the only things. I don't make judgments on emotion. I don't make judgments. My daughter hates it, but I just don't. Give me facts. Give me stats. Give me numbers. Give me correct stats, because you can make them look however you want. But that's the only thing I will be making decisions on. And I have a friend, she's my best friend, hates politicians. And when she found out I was doing this, she kind of went quiet. And her comment to me was this, and it was a fair comment: be different. Don't stand up in front of people and promise the world. Stand up in front of people and tell them how you're going to fix things. And so my goal, I truly do not know how to fix where we are from insurance to where we are going. We will not have universal health care in my life to where it is entirely paid for. I can tell you that now because of the system that is in place. I totally agree with Charles. I will not see it in my lifetime. To move from where we are now to there would be mountains. And I understand what it would take. But what I do want to do is I want to see what other countries are utilizing. Other countries pay a lot of money right now in their taxes. Americans aren't going to want to do that. I mean, they just won't. And then we have the insurance companies that are intercalated into our system. And as you had mentioned, it's over 25%. So what I'm going to do, though, is I believe in facts, I believe in research. It's actually what I've done for all of my life. And I'm going to see what other countries do, how they utilize it. I'm going to see how other countries are enabling the cost of drugs. Your drug costs over $273,000 a year. The drug on the that I happen to be working on, I work on multiple myeloma, $888 per pill a day. That's over $360,000 a year. I have read charts from patients, and it will say patient has no insurance, has to decline meds. That's not okay. It's not okay. We have to figure out, there are other countries that cap the total that they are willing to pay. There's a drug that I'm very familiar with, almost $6,000 a month. Canada pays $800. We need to do better. We have one of the brightest, most advanced science in this country. I know because I work in it. I work in it daily. I have worked in it for over 20 years. And yet, we can't utilize it in some of our people because we can't afford it. That's not okay. It's not. So what I'm asking is this. I may not have all the answers. I am willing to do the research. I will be in your, I will be doing town halls. I will be in your backyard. I will listen. I want to know what your concerns are. But when I go to Washington, I will have your back. And I believe, my friend who hates politicians asked me today, she goes, there was a governor in New Jersey. She just got elected. Somebody asked her, what's the biggest problem in our country today? And the politician floundered. And I thought for 2 seconds, and I said, hands down, it's our medical care. It is our medical care. Because if you don't have a healthy population, if you freaking don't get them vaccinated, God forbid, if you have people who are charlatans at the helm, who tell you to drink apple cider vinegar and that'll cure everything. But if you have people who don't believe in science, and if you have people who think it's okay for 42 million people not to have insurance because we can't afford it anymore, our population will be sick. And you don't want the cost. It is a lot more expensive to start healing somebody when they have advanced disease than when you can catch them at the beginning. And so we do need ACA. We do need Medicare. We do need Medicaid. This is not okay right now. Where we are heading is not okay. But if you elect me, at least we'll have a voice to try and head in the right direction. Thank you.
I just want to. It's easier. I just want to add to that Julie works full time. She has to work full time because you know what she's. Yeah. Oh, ouch. And she has a very big district, so she's going to do her best to get to it all. But she can use help. So volunteer to help if that's something that you really want to do, and I'm sure she can tell you how to do that.
I have a business card if you don't have it, and we have on my webpage, it's actually a volunteer page, and if you go on there, you're welcome to sign up for any facet that you are comfortable in doing. I will be doing town halls. Okay, my daughter's a senior in high school, but she thinks she's in college.
It's a big thing, okay?
It is.
Senior.
She's 18 today, so, but I do have my sons at Purdue. But anyway, so I will be doing town halls. I have been making the rounds, like I'm going to Harrisburg next week. I do know what El Dorado is. So, and I also want to visit the hospitals that they want to close. There are 6 in this district, guys. And those hospitals are crucial. They live in the farming communities. They live in the rural communities. And I was speaking to a farmer, and I said, people don't understand. I have worked on a farm. I've loaded more hay bales than I'd like to count. It's dangerous work. And other than just the farmers, when you remove those hospitals that are so crucial to those communities, you now have people, as the young lady had mentioned, driving 40 minutes to get care. People can't wait 40 minutes for a heart attack. You can't. So, well,
Are you ready for Congress?
I am. I'm running
You're running against Bost.
Yes.
Good.
It's just, for a national level though, the things like when Trump cut the funding for all of the, I used to work for a nonprofit, so he cut the nonprofit funding, he cut the funding, and like when he cut the funding for the Mayo Clinic, that was a huge thing. It's like, not only are we losing right now, those researchers who are the American researchers who are doing the work, we're gonna have a brain drain because they're gonna go to other countries.
They're already leaving.
They're leaving to go to places where they can actually do the work that they need to do. We're just losing everything.
There is so much funding being cut where I work right now, because that's what I'm in research. I have a friend that has been working on a drug. In fact, I had a conversation with her yesterday. She's been working on the drug for 5 years. It is a individual drug that is, it's made just for a person. And she's been working on it for 5 years, and I found out yesterday that her research will take her at least 1 more year before it goes into humans. It's time, it's money, and Trump is gutting it. Because he doesn't, his freaking, for anybody, I know a lot of people that couldn't stomach watching his January, no, his 60 Minutes thing was bad enough. No, watching his union address in January or early February, and they talked about transgender mice, and I about fell out of my chair.
Oh, yeah.
Yeah.
I have made genetic mice most of my life. I mean, it's just, and to sit there and go, you have idiots that are talking about things they don't understand. His entire administration, but when you specifically look at the medical aspect, firing all of CDC, one thing I would love to do, and this is when I get elected, I am going to write a bill that writes requirements for every administration, meaning you have to have 20 years of service as a physician before you're in the CDC, and you have to have at least 100 publications. You have to have at least a 2-star general with 4 years at that time and grade before you're allowed to work for the Department of Defense. This is ridiculous. We need leaders.
Yeah.
We don't need charlatans. We don't need Fox News people. We need freaking leaders.
Exactly.
And if you can't do the job, get the heck out.
And we're not even gonna even have CBS. They said Sunday I was watching a program, and they're only 2 months away for developing something for Alzheimer's, and it's cut.
Yeah, I just saw that too.
2 months away from getting it.
You can't start a lab up in a day. When you cut a lab and you cut funding, cells are gone. It's years.
Yeah, when I'm looking at, like your case where you've got 6 years into an 8-year study, well, you can't just go, you can't just go, okay, well, next year we're gonna do the funding again.
That's what
She's
people
not.
ask me. They're like,
She's
maybe
not.
it'll start again.
There's no
And
way
it's
around
too
it.
late because
Yeah.
people have already missed doses
Exactly.
of that drug,
Exactly.
and so the trial is ruined.
Exactly.
They killed their animals too. Some of the labs had to kill their research
Yeah,
animals.
because they couldn't afford them.
Because they couldn't afford them.
Well, guys, it's 10 after 9, so we kept you extra late. I apologize for that. I hope you got a lot out of this. There was a lot of information there. I really want to thank all of our speakers who came and told their stories and shared the information that they did. So let's give them all a big hand. And we all have to go make sure we need to contact our senators and our congressmen and let them know what we think about what's going on with health care. Okay. Thank you all for coming tonight. Grab a cookie on your way home. Thank you so much.